Hello, dear friends, I'm pleased to welcome you to our channel. Today I would like to address a very common question asked by doctors: how to determine the occlusion vertical dimension. I can tell you 6 to 7 ways how to determine the height of the bite. Let's count. The first is profile. That is the so-called Cephalometric analysis. It is an assessment of the bite height by profile. You practically use it all, if not every day, then every other day for sure, especially those who do prosthetics to patients with the adontia. And another method, the phonetic tests. The first test, for example, is the test M. What does it give us? This test gives us the height of the rest area, because the height of the rest area in turn is also a method for determining the height of the bite. So we measure the height at rest, subtract 2 millimeters and get the dimension you need. And another phonetic test? S pronunciation. S. There is a modified Lorrison phonetic test based on it, which was described in a book written by Oidman and Dabrich. This is a modified technique of the phonetic test S, and a special device was made for this, and the accuracy of determination of this test is 1/100th of a millimeter, because the patient feels contact with the plate up to 1/100th of a millimeter. From this height we subtract 2 millimeters as well. This is due to the fact that speech distance is 2 millimeters. What else can we measure? This is a so-called model analysis. How is the measurement carried out? Measurement is taken between the deepest surface of the vestibulum oris of the upper and lower jaw in the area of the frontal teeth. The distance according to the BP's concept is 36 millimeters. According to the Stab cranial system, it is 40 millimeters. What you should do, you just measure it and get the appropriate distance. There is a special Shinbachi index. Its measurement is related to the size of the incisors, their lengths and widths, and this index gives a recalculation in accordance with the distance between the gingival zenith of the upper incisors and lower incisors. If you're interested, we can analyze all these methods apart. Maybe we'll even make a video on this issue, or we'll make a small text file. But one can continue to discuss various methods, but the method that I use is a method of cephalometric analysis, Ricketts cephalometric analysis. We will analyze it today. There are no need to set a lot of points here. You will need to have a X-ray. You can practice on your own. I encourage you to do this. That is, just watch our video. You can calmly click on the pause at any time. You can zoom in, see where we put the points, draw the appropriate line, take the protractor and measure the height of the bite that your patient has. So what do we need? Alright, you see, I have X-rays of 2 patients, one X-ray of the patient with an open bite, quite expressed, and then we can evaluate and compare the data we obtained between the 2 X-rays data. So, first of all, we need to draw the Frankfurt horizontal. How do it pass? It passes from the Porian point, which is most superior point of outline of external auditory meatus. It is clearly visible on the X-ray, and orbitale point, most inferior point of margin of orbit. Porian orbitale, we got the Frankfurt horizontal. Next, we need to build 4 additional planes that will allow us to find the so-called geometric center of the mandibular ramus. So what do we need to do for this? From the deepest point on the front surface of the mandibular ramus, we draw a perpendicular line to the Frankfurt horizontal. Next, second point. The deepest point on the back surface of the mandibular ramus and draw a perpendicular line to the Frankfurt horizontal. Then what do we do? From the deepest point in the coronary mandibular notch, the notch between the condyle and the coronoid process, this is the deepest point, we draw a perpendicular to our perpendiculars. That is, what do we get? Parallel Frankfurt horizontal. That is, we have one line, a second line, a third line, and a fourth line. Here is the so-called mandibular notch. Find the deepest point and draw another perpendicular to the perpendiculars. That is, what do we get? We get such a rectangle. We cut off the excess and got, so to speak, a geometric outline of the lower jaw branch. Next, we connect the vertices of the resulting rectangle with a bisector. At the obtained intersection point, we have the point XI. Let's take a look on a chart. Once again, pay attention. The deepest point on the front surface, on the back surface, in the coronary notch and mandibular notch. What do? We got Frankfurt horizontal, draw a perpendicular to Frankfurt horizontal, a second perpendicular to Frankfurt horizontal, then what do we get? Two perpendiculars to our perpendiculars. And now what do we get? We get a geometric outline of the lower jaw branch. Connect the vertices of the resultant rectangle with bisectors and get the point XI. Then what do? We need two more points for our work. INS, anterior nasal spine, and another point is the transition from the deepest point on the anterior symphysis of the lower jaw to a bulge, that is a transition of the concave part to the convex part of the symphysis. The so-called point PM is the protuberance manti. This slide can more clearly show it to us. That is, once again, in order to determine the angle, how many points do we need? 3 points at least. Connecting them, we get an angle. So we have the main point XI, which we have built on the branch of the lower jaw by determining its geometric center, and 2 points in the anterior nasal spine and protuberance manti on the chin. That is, we have 2 lines, INS XI and protuberance manti XI. Thus, the angle between them is related to the height of the bite.